So we're going to look at disparities in sickle cell disease for women and girls. And from my intro, you know that is the work I do. So let's first define what sickle cell disease is, how it manifests, highlight the impact on women and girls with sickle cell, and identify ways simulation-based education can be used to reduce disparities. I'm going to presume not everyone knows what sickle cell disease is, so I'm going to do just an overview of it. So sickle cell is the most common, I always like to start with this, it's the most common inherited blood disorder in the world. So I kind of feel like we all have an obligation, honestly, to at least know what this disease is. It affects the shape and functioning of hemoglobin in the red blood cell. Okay, so our red blood cells are normally round, flexible. You'll see it on the left-hand side there. They're like a donut shape, just that the center is filled in, and they move through your blood vessels quite freely, and they're able to hold on to oxygen. The hemoglobin is what actually holds on to oxygen and takes it to your tissues around your body. On the right-hand side, you'll see a sickled cell. Okay, so you can see the cell is more oblong, it's concave in nature, it is more fragile. So normal red cells last about 120 days. Sickled cell lasts around 5 to 15 days. In addition, they're not able to even hold oxygen as well. So I don't have as much red cells flowing around my blood, and I also don't have as much oxygen flowing around my body to my tissues. Furthermore, sickle cells, and let me just see here, sickle cells, yes, I go to you. So sickle cells, the other piece that really I feel is a hallmark thing that you'll hear about the most is that they do cause pain when they stick together and they jam in the blood vessel. So you can kind of see a little bit in the background of the picture that there's a sickled cell here, a red cell here. And then as they flow through the blood vessels, they actually get stuck. And then they block off blood flow to your tissues. And those tissues, without oxygen, will start to die. That's painful. Everything in that process is painful. There's a few different genotypes of sickle cell. I bring this up only because it does relate to some of the research I'll refer to. Okay, so for those that don't have sickle cell, your hemoglobin is AA, meaning you got a normal A from your mother and a normal A from your father. And I am going to use mother and father in this situation, recognizing there are different genders and different relations that people have. In this particular situation, I am being strictly genetic around your two genotypes coming together. With respect to trait, AS, right? So I have one normal hemoglobin and I have one hemoglobin S. And so they come together. This gives you trait, carrier state. Those are the two main things you'll hear it called. So I have sickle cell trait, and so does my husband, so does my son, so does my father. And so perhaps that's one of the many reasons why I have so much passion for this particular condition. It says no manifestations, but I actually won't get into that because I have to keep myself focused on what I'm talking about today. Otherwise, I'll take the entire hour. So the other genotypes that are important with respect to sickle cell, hemoglobin SS is the most common. Okay, so one sickle gene from one parent, one sickle gene from another parent comes together. So to have a child with sickle cell, you don't actually have to have sickle cell, which I think is very important. You just need two parents that actually have trait. Have a child, you have a 25% chance of having a child. And this is how a number of children actually get born with sickle cell, is that their parents did not know that they had trait and that they had this chance. And they find out once their child is born that their child has sickle cell. It is, the disease is so impactful that we must know this information. And so for me, my child knows. He's only 10. He knows. When he gets married, when he's ready to have children, you got to make sure you do a blood panel. You got to screen the blood, make sure, check it out, see, does your partner have trait or disease, and then make some decisions, but make them informed. And so the other genotype I'll highlight is hemoglobin SC. Okay, so one hemoglobin S from one parent, one hemoglobin C. When these two come together, it is a sickle genotype that you're creating. And so this is another situation where there could have been a parent who has AC. They're like, they think their blood is normal, and it is AC. You don't have any symptoms. And then you have another parent, their blood, in their DNA is AS. And so when the one S and the one C come together and make SC, it creates sickle cell. So it's just really trying to bring awareness to the fact that being informed is super important. And if any of your children, your friends, your family have sickle cell or the trait, ensuring that they are aware as well. There are two hallmark conditions, but based on time, I'm only going to cover one. And so the biggest one that people generally know about is vaso-occlusive episodes, vaso-occlusive crisis. You'll hear either terms used. It's the initial trigger really for the cascade of pain that's associated with this disease. And then the subsequent dying, ischemia of tissues, dying of tissues, and activation of inflammatory cascades. So what that is all saying is, when it doesn't say it on there, but when oxygen levels drop, or when there's a trigger, extremes in temperature, stress, then there tends to be a change in that hemoglobin from that nice round shape into the sickle shape, and long polymers form. And when those sickled cells are flowing through the blood vessels, they roll along the blood vessels and they get caught, but they do activate other cells as they go. And so they actually activate an inflammatory process. And so along the vessel, right along here, is where some of the inflammation is starting. And here's where you can actually see some of the sickled cells, some of the normal red cells. You can see some of the white cells, some platelets. So it doesn't just involve red cells, it involves your whole kind of cell line: red cells, white cells, platelets. And so when this vaso-occlusion occurs, you can see hypoxia, which means no oxygen. So there's no oxygen getting to the rest of the tissues further down. Okay, so that's really a key piece here. Again, is it's pain, it's inflammation, and there's a cytokine release. There's a release of metabolites that can impact different processes. I leave it high level because I just want you to really appreciate what the disease is and then its impact. Okay, so complications of sickle cell, this really is to tell you it affects all your body parts. Wherever blood flows, the sickle cell can certainly impact you there. Let's get into women and girls. So contrary to the pain and sickle cell epidemiology study, which is called the PICE study, it's one of the landmark studies, and contrary to other studies, this particular one revealed no significant difference in pain experience between men and women. We're looking at percent of days of pain or number of pain episodes. One thing, though, that the study did notice is that from the SF-36, which is a measure of health tool, so a measure of health survey that was completed by all study participants, that tool showed women reported higher levels of bodily pain and more interference with normal work. So I kind of feel like what was really focused on here was around sickle pain in particular, but I wonder if some of the body pain that's being reported is actually still sickle pain. And because it's in women, we haven't really studied as much the hormone impact and just the difference of sickle cell in women. But it was interesting here for me that the increase in the interference. The study highlights also with men that men with hemoglobin SS, so remember we're talking, SS, have more days with pain crises than women with hemoglobin. What I found most fascinating, like I truly thank the organizers for asking me to do this talk, is what I found out, is that women with hemoglobin SC have more days of pain crisis than men with hemoglobin SS. Okay, so let me say that again. And so men with hemoglobin SS have more pain than women with hemoglobin SS. Women with hemoglobin SC actually have more pain than men with SC. And when you compare women with SC to men with SS, women with SC actually have more pain than men with SS. But what is the research all based in? Hemoglobin SS. There's not as much research for hemoglobin SC. So because I feel that we're not really doing this research, I actually asked our medical director yesterday, I was like, I found out this information. What do you think? He's like, oh, I've not really heard about this. It's because there's so much research to be done. So I do feel, in particular, women with hemoglobin SC are probably experiencing more pain crises than anyone really appreciates. And certainly when they go to the emergency department or interact with other members of the healthcare system, they're not going to know as much about hemoglobin SC because we don't even have the providers who know about sickle cell in general. So never mind now, genotypes to be like, oh, do you have hemoglobin SS? Do you have hemoglobin SC? Oh, you're a female and you have SC. Okay, let's kind of like unpack this a bit more. That won't come to mind because there's just not enough knowledge out there. So this is just me showing you what I just said, actually, and I won't belabor this because I've said it to you, and I'm a visual person, I like to kind of see it, but you'll see that it says 5.1 for men, right, with hemoglobin SS, and then under that, hemoglobin SC, right here for women, 5.1. Right, so it's pretty much equal. And then here, days in hospital, 3.1 for women with SC, 3.0 for men with SS. So maybe, I don't know, 5 years from now, you're going to see me on the research team doing something for this, because it certainly is a gap. Sex-based differences in manifestations and complications of sickle cell disease. This report comes from the Sickle Cell Disease Implementation Consortium. And they use the sickle cell quality of life measurement information system. And so this particular tool they used is specific to sickle cell. It showed that females had more anxiety, more depression, more autoimmune diseases. This one did show more pain frequency. So is it about how did you define pain and how did you measure it? The previous study, it was a 6-month diary collection plus survey study. And this was, I feel, a one-time, right? So if you do like a one-time versus something that's over 6 months, you get more value out of the 6-month one. So this is, I find, a problem with literature as well. You have to really look at the value of the data. Like, where does it come from? They had increased, let me move this little thing, sorry. They had increased VOEs, vaso-occlusive episodes, and they had increased hospitalizations along with increased opioid use. I'm going to keep moving because I see my big part of the technical pie took up a little bit of time. So I'm going to move forward a bit. Is hemoglobin F the answer? So what we have found in the literature is that women have higher levels of hemoglobin F. Hemoglobin F is one of the very elements in which we are really looking at in research as a possibility of decreasing the concentration or the number of hemoglobin S. And so hydroxyurea, which is one of the medications you can take, one of the very functions of it is to help increase hemoglobin F. Now, women already have a higher hemoglobin F. They also have a higher life expectancy. So is this the path we need to really drive on? I do feel if you spoke to a researcher, they would say we're on this path. We are driving this path forward, that it is one of the very valuable things that we should be looking at is how do we increase hemoglobin F across genders and the lifespan. In particular, reproductive and sexual health in women and girls with sickle cell disease. I probably could have spent the whole 15 minutes on this, but I want it to be broad in nature, not to just focus in on this part, because it impacts more than just reproductive and sexual. So girls and women with SCD are at higher risk for having pain with menses and also thrombotic or clots, right? Or, thrombotic or clot, same thing, with estrogen-containing contraception. And please, if someone wants to tell me to stop talking, just unmute yourself. I will not be offended, because I know I'm a little over time. I have about 2 more minutes. Unplanned pregnancies are common, highlighting the need for proactive rather than reactive reproductive health care. We need more specialists to collaborate on care. We need more information. We just need more focus. Right now, approach is very much episodic instead of lifespan approach, which would really benefit our patients, especially women and girls. Okay, so I will move past this, but just to know menstruation morbidity, again, underappreciated, undertreated. It contributes to poor quality. It contributes to anxiety and depression. It increases the frequency of pain episodes and decreases quality of life. So if we see increased anxiety and depression, but we're not really looking at the impact of menstruation and the reproductive and sexual health functions of women, then we're not really going to be able to find the answer on how do we support our patients better moving through through the particular stages of reproductive health and wellness. This is my last slide. On the left-hand side, disease-modifying therapy. I did mention hydroxyurea. It's the only medication available that's shown to increase hemoglobin F. It extends life. It decreases pain. It decreases hospitalization. But there's also discussion around, does it impact childbirth? So when women become pregnant, we ask them to stop their hydroxyurea. That's currently what we're doing, but there's some talk and definitely some literature moving towards hydroxyurea being okay. But we stop hydroxyurea for the risk to your fetus. So this uncertainty, this anxiety and depression, to me, part of that comes from making a decision. Disease-modifying therapy, do I take hydroxyurea and possibly affect my child? Or do I take it for a time frame and then stop it when I'm gonna get pregnant? There's a lot of thought that has to go into that, obviously. And then conditioning regimens. If there's actually a curative therapy, which transplant is a curative therapy, but the conditioning regimens are so myeloablative, meaning they kill all the cells in your body, right? They want to kill all the bad cells, really, but they kill a lot of the good cells too, to kind of wipe your slate clean and then reset things, if I talk high level. There's gonadal failure and infertility associated with those particular regimens. What are the gaps? lack of providers who identify as Black or women, lack of expertise in area of women and girls with SCD, limited research available to support guidelines and care pathways, and lack of knowledge also amongst patients, caregivers, and providers as to the tests. Oh my goodness. Oh, simulation. Simulation-based education, it's an educational methodology that is based on experiential learning, meaning, learning where I'm able to actively be involved. I'm touching, I'm feeling, I'm hearing. So it's hands-on, it tends to be hands-on, but it's really in allowing me to get the true experience. It incorporates reflective practice utilizing active learning strategies. So that just really means that you're doing an activity, you're reflecting on what you did, and then you try it again, really looking for improvement. I'm in a safe environment. I'm not doing it on the patient. I'm not doing it around, during a very stressful time, which we can recreate though in the simulation. But we're trying to make it in a safe space so that we take away that fear and anxiety that prevent you from performing in the way you should when a patient needs your attention. We take that away so you can practice it in a safe environment so that when you go to the bedside, you'll be able to provide that high level of care. It involves all three domains of learning: cognitive, right? My thoughts. So we can teach you stuff to, really think about what you're doing and why. And if you don't think about it correctly, let's pause and really reflect on, well, how did you end up there? How did your frame of thinking take you there? So recorrecting frames. Psychomotor, hands-on, affective, your emotional pieces, right? Your emotional learning. And so I have a couple examples how simulation could be used. So for healthcare providers, in particular with women in health, with reproductive and sexual health, we could look at case studies for sure. So we could do a case study of a patient and do an in situ simulation. We certainly could do a simulation where we have a patient who's actually present, maybe in a clinic, and they've come to us today to get some counseling. So we can move through the process, like how would we do that? What would we say? What questions would we ask? Do we have the knowledge? So we can use simulation to work on that piece, and really then what team members would we need to tap into? We also could do an escape room. So I could create like an escape room and team members go into this escape room. And the only way you can escape is when you answer questions correctly and then you get a clue. And this clue leads you to a code, and the code will get you out of the room. This is all simulation. Simulation is recreation of reality. That's recreate reality. So the questions I'm asking you are going to be questions that you would be facing in your clinical environment or your interactions with your patients. For patients and caregivers, education about what reproductive and sexual health is could certainly be done with simulation. So if I had patients and families, I also feel like maybe like a virtual interactive puzzle escape room. So simulation itself is not just about mannequins. And so that may be what people think about when they think about simulation, like the mannequin, and please don't call it a dummy, it really hurts my heart. But a mannequin, right, that's like, looks like a patient, and then you kind of like, it's all only when they're coding. How do you resuscitate the patient? Simulation can go across the board. You can use simulation for planning. So maybe we want to add reproductive and sexual health to our supports to our clinic. And we want to know how do each of the team members participate in that. So we could do a tabletop simulation. We could say, okay, the patient's going to come in. This is their age. This is their history. Bam, let's go. Who would see them first? What questions would you have? Okay, who else would you need? And then we'll say, okay, well, you're here. Well, what would you need? What would you say? Okay, so then it really, as a team, we can figure out what do we need for the patient? Where are gaps and barriers? Thank you. Thank you so much.
It says, we learned in high school years ago that the reason sickle cell anemia persists is because it provides some immunity to malaria. Is this true? Can you share a little bit?
It's not a good thing, but yeah, so the original, how did sickle cell kind of come to be? This shape of the red cell changed to protect against malaria. And in that creation of that protection, it led to this debilitating, devastating condition. And so the perpetuation now of disease is through the trait. But yes, it is malaria. And so why do we see a high predominantly Black? I didn't even go into Black into this for this particular conversation, and I didn't really get deep into bias because the reason we see predominantly Black people impacted by sickle cell is because it tends to be found in largely endemic areas of malaria. And a number of areas that are endemic of malaria are found in Africa, Mediterranean, and other countries close by. So just to know that piece. Thank you so much for that question.